Okay, part 2 of chapter 70. We're going to talk about glomerulonephritis now, which is the third leading cause of end-stage renal disease. I kind of kept up with what your patients with dialysis had going on with them. A majority of them, I will say, was hypertension and diabetes. You had a couple with polycystic disease and some that had started off with glomerulonephritis. So, this is a glomerular disease, and if we remember our picture that's on the, I hope, now on the board in the classroom, you know where the glomerulus is, and you know that that's where all the blood flow comes in. So this is a disease of that glomerulus. It generally follows an infection, and that's usually a group A beta hemolytic strep. So you need to ask your patient if they have any history of a pharyngitis or tonsillitis, usually about 2 to 3 weeks before all the symptoms start appearing. An antigen-antibody complex forms, and the body actually starts to attack the glomerulus. So this is an autoimmune. All right, these are the typical signs and symptoms and what the disease looks like. It is an antigen-antibody complex in the glomerulus. You get inflammation, and of course, anytime you mess with the glomerulus, your glomerular filtration rate goes down. You want to also assess for skin lesions because that could be a possible source of infections if they haven't had the tonsillitis or anything. They appear with shortness of breath, edema, crackles in the lungs, an S3 gallop. The most common edema with them is the facial and periorbital edema. That is the most common presentation. Their urine has an increase in specific gravity as well as these other symptoms that are listed here. And they also, when you're assessing, you need to ask if they've had any recent travel, because they could have caught something on a travel trip as far as an infection, strep infection. All right, intervention-wise, we're going to monitor their temp, of course, INO, weight, edema, because we're treating their symptoms, okay? No carbonated drinks because they contain sodium. Their bed rest, usually on bed rest until the hypertension and the hematuria is gone. They're usually on a fluid restriction, so their fluid, and this is with anytime you have a patient with fluid restrictions, they'll either put a specific amount or they will daily look at the output for the day before and add 50 to 60 milliliters. If they have good renal function, that's fine. If you've got a patient that, you know, has low output anyway, they may give a little bit more and monitor their them for edema. But the extra 500 to 600 milliliters that you add to the 24-hour output from the day before helps to compensate for the measured and insensible fluid losses that you have through through breathing and the GI system. All right, patients can develop chronic glomerulonephritis, which occurs over 20 to 30 years, and they may not even know that things are going on or that they're having injury to their glomerulus until they have renal problems. Remember, there was a tremendous amount of nephrons that had to be affected before you started seeing renal symptoms. So these patients, chronic glomerulonephritis almost always leads to end-stage renal disease. And they may be up here into stage 2 and stage 3 before they even know that they have had problems. Okay, the next one we're going to talk about is nephrotic syndrome. There's a chart on page 70-6. I'm sorry, I did it again. Chart is 76. The page is 1593. Okay. It can be caused by glomerulonephritis. And the big thing in this one that jumps out at you is that they have a tremendous amount of protein in their urines, greater than 3.5 grams a day. So if it's going in the urine, what do you think happens to the protein in the blood? It's going down. So they are hypoalbuminemia, less than 3 for their serum albumin. You know, a normal serum albumin is 3.5 to 5. So you're going to see hypoalbuminuria, and you're going to have a lot of protein in the urine. And what happens with the chronic glomerulonephritis, they get big holes. You know, normally we don't leak. The protein does not go into the filtrate, but the glomeruli are damaged, and you have a lot of protein going into the filtrate and out through the urine. They have also have high cholesterol, high triglycerides. The hyperlipidemia is caused by altered liver function. They can have a foamy appearance to their urine from getting fat in the urine. They have weight gain and fluid retention. They have a poor appetite, and of course they have hypertension. Assessment-wise, as I said, you're going to see massive proteinuria and the hypoalbuminemia are the two biggies. The periorbital edema, their edema is most noticeable in the AM and is dependent, as in, you know, when they're sitting, their ankles, when they're lying, their sacrum or scrotum. Treatment involves immunosuppressive agents because it's generally caused from an immunosuppressive type disorder. And our goal of our treatment is to relieve symptoms and prevent exacerbations from occurring. They have periods of exacerbation and remissions. We want to prevent complications, which the end is progressive kidney damage. So we're trying to delay that kidney damage. The blood pressure control is going to be the most important to prevent it, which we like to keep below 130/80. We're going to use ACE inhibitors because they also they also decrease protein loss in the urine. We're going to use ARBs, angiotensin receptor blockers, for their blood pressure. Heparin can help prevent clots and decrease urine protein, which helps to, if you decrease clots, that helps to decrease renal insufficiency, increases blood flow. Their diet will be decrease in sodium, a moderate protein diet of about 1 gram per kilogram per day. Small, frequent feedings are usually more palatable for them. Of course, the protein in the diet is going to depend on, again, their GFR. We use statins because of that increase in cholesterol and triglycerides. We're going to use some statins because with these patients, diet control is usually not successful. Vitamin D. Sometimes you may see patients and you'll think, well, why are we giving them albumin? Because, you know, albumin is protein. We need protein. So with a low protein in the serum, we may need to give them albumin and then diurese them a little bit. But we have to replace, not diurese them, but we have to replace the albumin that they're losing. Little FYI, when treating children with prednisone, if you have a child who is getting immunosuppressive therapy, anytime, not just for this, a lot of times you'll see them go to every other day treatment because they're trying to avoid altering their growth at that time, because that can be a problem, the growth failure, if your children are on long-term immunosuppressants. All right, so vital signs, INO, bed rest, all these things are interventions for nephrotic syndrome. Nephrosclerosis, just like arteriosclerosis, we have thickening in the nephron blood vessels, those vessels that are supplying the kidneys. So, of course, you're going to get hypertension, okay? So the big thing is controlling that blood pressure. ACE inhibitors are used, and remember, a side effect of that is cough that comes from the angioedema. And blood pressure control is very important for these patients, so they don't end up, we're trying again to ward off that kidney damage. Renal vascular disease, this occurs usually very suddenly. They have a sudden increase of hypertension. Occurs more often in 50-year-olds and greater. And they can have some renal stenosis, which leads to the atherosclerosis. Alright, diabetic nephropathy. Unfortunately, I do not think this video is available anymore. It was a really good discussion of diabetic nephropathy. You know, diabetic is probably our #1 cause of end-stage renal disease, and it's very progressive. And what happens is that the high sugars damage the blood vessels. They dilate the afferent arteriole, which increases fluid, increases capillary pressure into those glomerulus, which causes glomerular destruction. And it also causes sclerosis, can lead to sclerosis of vessels. Unfortunately, as this starts to occur and as your renal function goes down, you may see patients that don't suddenly need as much insulin as they did, because remember that the kidney excretes insulin. Okay, so if the kidneys aren't working very well, then we have more insulin available, and they actually may be taking less insulin, and they think that's a good sign, but actually that's not a good sign because their kidneys are not working as well, and they eventually, you know, are going to end up with end-stage renal. That's just a path to end-stage renal disease. Okay. Cyst and benign tumors. Of course, we've always got to see if it is cancerous. And a cyst is just a fluid-filled sac that can or that may or may not be cancer. Oops, there's a slide missing here, so let me tell you about it. Adenocarcinoma of the kidneys is probably the most common. If it's a tumor, it can cause anemia and erythrocytosis related to the production of erythropoietin, because tumors will either increase or decrease the production of erythropoietin. So if they decrease it, they're going to get anemia. Hypercalcemia occurs because of tumor production of parathyroid hormone. Hypertension occurs because of increased renin levels. Complications can be metastasis to the adrenal gland, liver, lungs, long bones, other kidneys. The other kidney. All right, systemic effects that can occur here they are. Erythrocytosis, hypercalcemia, and I just went over what was causing all those. Assessment-wise, they may have dull flank pain. They may have a palpable mass. Hematuria is usually a late common sign with these patients. Interventions focus on controlling and prevention of metastasis. Non-surgical management. The radiofrequency ablation, slow tumor growth is usually when that's used. Chemotherapy really has had limited effects. They may use biological response modifiers such as the interferons and interleukin-2. If necessary, nephrectomies are performed. Pre-op, you need to do patient teaching on, let them know that they may have drains, they may have catheters put in, afterwards. Blood loss is of major concern because these tumors are usually very highly vascular. Some patients require radiation after nephrectomy. Postoperatively, these patients, because remember the adrenal gland sits on top of the kidneys, and generally they'll remove that adrenal gland. The other adrenal gland will pick up and take care of that, but sometimes they can develop adrenal insufficiency. If they have large urinary output followed by hypotension and then a subsequent loss of their urinary output, you should suspect either hemorrhage or adrenal insufficiency. When you remove that adrenal gland for a while, they may need to be treated with steroids until the other adrenal gland can take over. Post-operatively, pain management, you can use cold compresses. Respiratory problems can be an issue because of where their incision is. You know, they've got a nice flank incision which sits right there around the diaphragm, so taking a deep breath is going to hurt. And turn, cough, deep breathe is going to be very important with these patients, using incentive spirometers, encouraging that, and they need to know about this pre-op so they'll be prepared post-op for it, because that can really be an issue with these patients. All right, here are some other post-op monitoring. Semi-Fowlers may be more comfortable for them. You can read. All right, what should you do to monitor for signs of post-op bleeding? Stop the film, write down a couple of things, see what you can get. You should have checking their vital signs for hypotension and tachycardia. You should look for abdominal distension, decrease in their urine output, decrease in their level of consciousness, and check the linens. Think about where their incision is. If they're laying on their back and they start having hemorrhaging, it could be coming out in the back. They could be laying on all that and have lost a significant amount of blood before you realize it. So that's important. All right, renal trauma. A pedicle injury is usually from a laceration or break in the renal artery or vein. And these usually occur from some type of trauma. And we look for that by looking for bruising over their flank and lower back, which can be secondary to retroperitoneal hemorrhaging. These patients are usually put on bed rest until required, until gross hematuria clears up. We can use vitamin K, platelets, fluid replacements, Paxils, whole blood, albumin. And they may end up requiring, though, a nephrectomy or a partial nephrectomy.